So this morning, working on Mr. Bob. He's been gracious enough to allow me to continue to work on him, and we're focused on his tricep survey group, gastrocnemius, both heads, and soleus. Of course, plantaris is in there, but plantaris doesn't get any glory in the naming. But when I started, his ankle was rigid. It wouldn't dorsiflex at all. It's in the plantar flex, and he does use an AFO to walk for gait training. But we did upgrade his AFO to one that can allow some dorsiflexion so that he can better translate and start to get that toe off effect in his gait patterning. So the importance of his gait pattern improving is having some of this mobility in his ankle to where we can graduate from this, because he's starting to use the tissues. And the etiology of the stroke had all these tissues binded down, locked down. So I released the tissues using a Vasia microcurrent device to calm down inflammation, manual therapy techniques with rock blading, and a myofascial cream from Cryoderm. And now we have his ankle that can circumduct, that can invert and evert, and I can even do the modified Ashworth test and get a little clonus, but it's starting to get less and less. But I can start to dorsiflex his foot so that now if I put the calf in a stretch, he can start to fire it to toe off. So the AFO serves a good purpose to keep from drop foot, because tibialis anterior isn't firing yet. He's not lifting his toes voluntarily fully yet, but we will. So but if we let him continue to walk with a rigid lock 90-degree AFO on, he'll never achieve this ankle mobility, and that way he'll never walk properly and balance himself as his life goes on. And it'll always be a problem, keeping him at risk of falling. So we don't want that happening. We want him to have his balance. We want him to have his full mobility back, and he's achieving it, thankfully to say.